Okay, I see the strike of 11. I think we could go ahead and kick off. So just start off with saying hello to everyone and thank you for joining us on webinar 2 of the Telehealth webinar series. The webinar today is being recorded and will be posted to our website. We will send the recording and slides to all participants at the end of this series. ACHE credit is available for the session. If you would like ACHE credit, Caleb Lazinski will be sending out an email after the webinar today to link to the survey. I'm Mike Rowland. I'm the Telehealth Program Specialist for the National Rural Health Resource Center, which is providing the webinar today. Please do us a favor and connect your video feature by selecting the camera icon in the lower left corner of your screen. Your audio is muted by default to avoid any background noise and feedback. Please remain muted unless you have a question. To unmute your line, please select the microphone icon in the lower left corner of your screen. If you dialed in, please press *6 to unmute your line. You can also communicate through the chat box, which is located at the bottom ribbon in the middle of your screen. If you haven't already, please do take a moment and add in your name, title, and organization in the chat box so we know who's joining us today and to help us give a better feel for the audience on the webinar. The National Rural Health Center is a nonprofit organization dedicated to sustaining and improving healthcare of rural communities. The center is the technical assistance provider for the Delta Region Community Health Systems Development Program. The Delta Region Community Health Systems Development Program is funded by the Federal Office of Rural Health Policy and in collaboration with the Delta Region Authority. The center is committed to diversity, equity, inclusion, and anti-racism, and building a culture where difference is valued. You can learn more about our commitment on our website. Before we get into today's session, I wanted to take this opportunity to let you know about some upcoming webinars. So on March 30th, we have the National Health Services Corps webinar. On April 5th, the Federal Office of Rural Health Policy webinar Part 1, Welcome to FORP. On April 12th, the Federal Office of Rural Health Policy webinar Part 2, Federal Grants 101. Okay. And as I'm introducing our speaker today, Caleb's going to be pulling up the polling question for today. These polling questions are based off a confidence scale and help us measure knowledge gains for our webinars.
Mike, and it does look like there is some technical difficulties going on with Zoom, not letting me pull them up right now. So we will try again at the end.
Okay. All right. No worries. Then we'll go ahead and introduce David. So our speaker today is David Fletcher, MBA and Associated Vice President of Telehealth at Geisinger. He's worked for 20 years in the healthcare industry, and he currently oversees all facets of telehealth and the EICU program with 160 employees, serving Geisinger's 10 hospitals, campuses, and more than 50 community clinics and 15 urgent care clinics, which serves more than 2 million residents in Pennsylvania. In July 2020, the program was recognized as the #1 national telehealth network at the Teledoc National Telehealth Innovation Forum. And with that, I think I can turn it over to you, David.
Great. Thank you so much, Mike. I really appreciate getting the opportunity to speak to the group today. And thanks, Caleb and Kim as well. I'm always really happy to talk about telemedicine in general, and then particularly telemedicine for older adults is kind of particularly near and dear to my heart. I think there are maybe some misconceptions out there that sometimes stand in the way unnecessarily, I think, of continuing to provide this kind of advancement in care for really all patients, regardless of age and other demographics. So very happy to talk today. Let me advance my slide. There we go. So as you mentioned, I'm AVP for telehealth at Geisinger. For those of you who don't know, Geisinger is a fully integrated health system. So we have a health plan, the 10 hospitals, multiple clinics, located largely in kind of central Pennsylvania and also in the Northeast. A very rural, kind of sparsely populated area. Not a lot of influx of new people coming in, and so we're kind of aging in place. So our demographics skew older than the typical population across the country. So, and as you mentioned, we cover 2 to 3 million people kind of in this central part of Pennsylvania. Now, Geisinger, partially because we do have a health plan, one of our big strategies is that we believe that the closer to the patient's home that we can deliver care, but both the less expensive it is to provide, and also the more convenient it is for the patient, which is great for me as a telemedicine person, because I think, oh, well, great. Telemedicine is a key tool to provide care closer to the home, either their neighborhood clinics, their closest hospital, and literally into their home, now increasingly with some of the waivers we've had. So that's on the plus side. On the negative side is, as everyone, as I was starting up here, everyone was like, "Oh boy, tough break that your population skews so much older because we know telemedicine. It's great. It's a great idea for folks who are millennials and folks who were born with an iPhone in their hand and are tech savvy. But I don't think the older folks are really going to like it." And so I think, some of the, obviously the explosion in growth we've had in telemedicine over the last, 4 or 5 years has really allowed us to test and really question some of those assumptions. So, we'll dig right into, some of what we've been able to find at Geisinger, is that, when we do our satisfaction surveys, we see very broad-based high satisfaction with telemedicine, and including the older age groups and really across all demographics. When I look at the satisfaction surveys, I can't tell someone who is a good telemedicine candidate and someone who is not. They're really not demographically. There's no way you can look at someone and tell that this person is so telemedicine or so not telemedicine. So we really have tried to steer away from some of those preconceived notions about that. Now, there are some folks who will indicate in a survey, I don't really love telemedicine. I miss getting to see the in-person front desk staff or whatever it is. But I don't see a correlation between that and a certain demographic group. I think it's, as much as anything, probably personality. And so we see, looking specifically at the age range between 65 and 79, that we have over 80% expressing satisfaction with telemedicine. And this was in the early days of COVID, really, when we were still kind of getting everything ramped up. And it's, to me, an interesting point was that when we compare our older population to older populations across the country, our population had slightly higher satisfaction rates. And I think the reason for that is because we've been very conscious, because we had to be, frankly, because of our population, we had to be very conscious about making the workflows really easy. And so when we schedule someone for a telemedicine visit, we have integrations built with our EMR and all that, so that when we schedule it, we automatically fire out a link, either to their email or to their phone. So we text it or we email, and the patient, all they have to do is click on that link, and it gets them into the secure room. And so they don't have to download it out. They don't have to go through a portal. They don't have to do an elaborate login process. We do have an automatic consent form that pops up and they can sign, but it's very easy for them to get in, which is great for our older population. But by the way, it's really great for everybody. I appreciate that myself. I've been in telehealth 20 years. I hate having to go through elaborate processes. So it's good for everybody. But equally importantly is it opens the door for telehealth to everybody, really, regardless of their technical skill, and obviously age and every other demographic you want to come up with. another interesting point was then, and it's, it's not just the recent retirees who love it, it's also folks over 80 years of age. They had an over 75% satisfaction rate. So again, I work really hard sometimes, honestly, to make sure that providers, and I talk with other health systems as well. You cannot assume that, oh, that 90-year-old man is not going to be a telemedicine patient. There's no way. And like, no, if you're thoughtful about how you design the process, in fact, you can make that patient's life much easier, because that patient may have particularly trouble, difficult travel circumstances and, other issues that they've got to kind of work through. So, and if done right, you absolutely can make it where they'll appreciate the ability to have telemedicine. So we've really tried to debunk that assumption. There's a certain intuitive thing to it, and I always think of the phrase, the old saying, it's not the things that you don't know that get you in trouble, it's the things that you know for certain that just ain't so. And I think this is one of those things that people just assume, like, oh, not for the older people. And it's like, it really is not so. It's entirely dependent on how you set up your program. So some of these are actual survey responses we've gotten from some of our patients. You see a neurology patients, wonderful service. I'm disabled and don't drive that far. I feel safer doing the video visits as well. So, a good example of, it's not just convenience in some cases. In some cases, it really is, allowing them to get care where maybe they couldn't because they just physically couldn't drive to their appointment. This appointment was super simple to set up, much easier to go to than if it were in person, from an OB-GYN patient. A gastroenterology patient, I actually liked the video visit, was more relaxed. And I always laughed in the first 6 months, particularly after COVID, when we were taking these surveys. I'd say about half of our survey responses had the word "I actually" in them. And I think, kind of indicating there was a fair amount of surprise of, I think, hopefully how easy it was and how helpful it was. But, it was a bit of a learning curve for everybody, including our patients. It was a new way of having care. So again, you see, of our neurology patients, I actually love this option. Since COVID started, I now work from home. I didn't have to take extra time away from work traveling to and from the visit. It was an awesome alternative. Family medicine, I felt the doctor was more attentive and allowed more time for discussion and explanation than an in-office visit. And I think, all of us probably appreciate the ability to not feel rushed and be able to talk to our providers. And I think certainly our older patients appreciate that as well. And so I think there are benefits. It's not even just an even swap of, well, it's more convenient, why not? I think there are times where it actually provides a benefit to the patient and maybe to the provider as well. So that was all great. I'm feeling great about, okay, telemedicine, we're a full go, we're going to continue on. And so that survey that we've talked about so far, that was taken pretty early stages of COVID. The survey I'm showing now was taken, what we now know, about halfway through the bulk of the COVID pandemic. And so we asked again, okay, what's your satisfaction? And in line with what we saw, you see, between somewhat and very satisfied was 83%, 12%, kind of, I'm good either way. Only 4% displaying some level of dissatisfaction with telemedicine. So I was like, okay, that's great. That's in line with what we're seeing. And so then the next question, which I assumed was almost a given, was how willing would you be to use the following types of telemedicine services in the future? And this particular, what you're seeing here is specifically for video visits. And you can see that, yeah, it's over half who are very or somewhat willing to continue to do telemedicine, but only 59%. And so there's kind of a disparity between the satisfaction and desire to continue doing it, which surprised me. And you can see even more concerning, 26% actively show some concern about continuing to do it. So fortunately, we asked a couple for deeper questions on that. And so, okay, well, so what things about telemedicine do you like? And I think by and large, it's the things you'd expect, not having to travel, just generally more convenient, not having to be in the lobby or waiting room, not having to be around other sick people, which is maybe particularly a friend of mine during COVID. So, you know, all the things you'd kind of expect. But then we asked, okay, well, so then what concerns, if any, do you have about using telemedicine going forward? And you can see the big one was, well, I'm worried exams might not be as complete as in-person visits, which it's obviously completely valid question and concern. And to me, it was a real eye opener. Probably shouldn't have been, but it was for me, because I was so focused on, oh, okay, it's great convenience for the patient. It's all those survey responses. Now, I was focused on this question, but I had in mind as my audience, it's like, oh, we got to explain to policymakers and our executive leaders, like, what the downstream effects are, and, you know, how we're operationalizing this, you know, so that they continue to allow it at the policy level, and that we truly understand what we're, you know, what the ramifications are of this big sea change and how we're seeing patients. And I think, to me, this was a hugely eye-opening response, in that I realized we also have to share that with our patients, and that this is a very new way of being seen by their providers, and we need to be very transparent about why we're offering telemedicine, when we choose to offer telemedicine. Is it a good idea? Are there downstream benefits from doing it? Is it, we're kind of indifferent either way? It's, you know, it's if it's convenient for you, we'll do telemedicine. You know, we've got to have that kind of transparency with our patients, because, you know, obviously they want to make sure that they're getting the right level of care. And we can't just assume that, well, if we offer it, they'll know that that's what we're doing. And so a little bit of a deeper dive here. And this is where the one area where I really see discrepancies or just between younger patients and older patients. So this graph is looking at, okay, kind of with the idea of like a post-COVID, what do you think there is going to be good for telemedicine as a survey? And you can see general broad acceptance of like medication review, refilling prescriptions. Sure, that makes sense. Follow-up visits generally, but you're starting to see kind of a discrepancy between the under 65. So the under 65 is kind of that middle bar, and then the 65 and over is that far right bar. And you see there's a difference there, that maybe the 65 and older, not so sure. And then the really big difference on ongoing care for chronic conditions. Under 65, very highly think like, yeah, that makes sense. Of course, I'd want to do that telemedicine. Over 65, only 36% think that. And so I think, you know, this is, and you know, really same on behavioral health, same thing. I mean, that's a huge way of how we conduct behavioral health now. And so I think, to me, this really highlights that, you know, we've got to explain to our patients that, you know, this wasn't, I mean, initially, yes, because we were prevented from doing telemedicine before COVID because of a lot of regulations. And then COVID prompted those regulations to be waived. And so we started doing telemedicine. And so I think there was a bit of a perception that, okay, this is like an emergency measure just to get by. Is this really how we should be doing care going forward? Which is a very legitimate question. And I think that's where we've really been digging into our data to answer that question ourselves, you know, and again, with the idea of like, oh, our providers and our policymakers all need to know like what this is going to mean, but we've really got to share that with our patients as well. I think, you know, this data really demonstrates that. They love it. They think it's convenient. They have high satisfaction for it, but they haven't yet been told whether this is the right thing to do medically. And so one of the things we did, we actually created a video after this with one of our pulmonologists, Dr. Simonelli, and put it on our website, kind of like for frequently asked questions. And he talked about like when he likes to use telemedicine, some of the benefits he sees for his patients. But then we asked, you know, are there times where telemedicine isn't appropriate? And he said, yeah, absolutely. You know, there absolutely are visits where I need to have, you know, be hands-on with that appointment, and we don't offer telemedicine for those visits. You know, if I only authorize people to schedule telemedicine when I'm comfortable that I'm going to clinically get everything I need to out of that visit. And I think that was a big thing that, I learned through this data, is that we really have to we can't just assume that patients will assume that, if we offer it and if it's a convenient to them, that, oh, well, great, then that's what I want to do. They want to know that they're getting good medical care, and rightfully so, certainly. So with that in mind, so we know, okay, we can't just assume older folks are not going to like telemedicine or can't do it. They want to know that it's medically appropriate, but if so, they like it. And so how do we build programs that will work for everybody, including maybe people who have maybe medically fragile, maybe don't have technology in their homes? How do we start to really build programs for them? And so one of the programs that I'm particularly proud of at Geisinger is called the Geisinger at Home program. So this is a very specific program. This is not, when I say Geisinger at Home, that's the title of the program. It's not just all of our in-home telemedicine, which is now like 12% of our outpatient visits. This is a specific program sponsored by the health plan, and we target patients that have multiple comorbidities. They're typically older. They have very high risk of being readmitted to the hospital or going to the ED. And so the health plan said, okay, let's, we're interested in trying to help these patients and members, and even if it requires kind of a more resource intensive approach. And so what we've done is we send out either a community health assistant, called CHAWS for short, or a nurse. They will physically go to the patient's home, and they'll do a lot of things. They'll arrange social services when needed. They'll certainly look at their ability to get healthy food, any trip and fall kind of worries, things like that. And then in the early stages of the program, if they had a medical concern, they would actually call the doctor. The doctor would physically get into his or her car, drive to the patient's home, and check on them. Now, when I got to Geisinger about 4 years ago, I said, man, this is a great program. This is really cool. We can make this so much more scalable. Rather than the doctor driving to the patient's home, why don't we use telemedicine to bring them into the patient's home? That way, that same doctor can see 20 people in a day instead of 2. And so that's what we did. And so now the CHAWS will go out with a little kit, and it's got a MiFi. So we're not dependent on the patient having a router and telemedicine or internet access. They'll have a tablet, and then they'll have the peripherals that can plug into that tablet. So we can have a stethoscope, we can have an otoscope, a handheld camera, which has really high definition and they can really see the skin. And then they essentially facilitate that visit for the physician. And it works really well. Our patients really love it. And I have a video, which I will play, which kind of shows how this program works. And
by being watched more carefully, I feel like somebody's there for me. If I ever need them, all I have to do is pick up the phone.
I love communicating with patients and caring for the patients. Whatever they need, they call us on the phone.
Geisinger at Home is really a new model that actually pulls off a lot of things that we used to do in healthcare maybe 50 years ago. So what we've really done is identified those individuals who have complex medical conditions, who may have hard time getting out of their home to get into their doctor, whether it be their primary care or specialist. And we take a team of healthcare clinicians out to the home and really try and help manage their medical conditions in the home.
Hi.
Hey Sarah, how you doing?
I'm doing fine.
Long time no see.
I know.
Oftentimes we see patients where they feel they need to see a doctor, but they're too sick to go to the doctor. So in most cases prior to Geisinger at Home, they'd be dialing 911, or they would have their spouse or their children bring them to the emergency room. So we're able to bring that access to them.
It's wonderful. I mean, it really is to have to, especially when the weather is so hot. Then it's the winter and it's too cold.
We have seen a pretty significant drop in both hospital admissions and ED visits as a result of the program. We still have work to do. We're continuously enrolling. We've identified, believe it or not, about 10,000 patients who probably need some of the services, or at least need to be evaluated for the services.
I think that it's a privilege to be able to go into somebody's home. I think that, you know, it brings down some barriers on the patient side to let us come into their home, to really see all the different things that may, you know, be driving some of their medical issues.
As long as you're okay with that,
That's
Jen can
that's
help
fine.
arrange that.
Yeah, if it's
Okay.
if it's a weekly draw on
Yeah,
her, I
it's a
can
weekly.
set it up with them and they can come weekly
Good.
for you.
Good,
Okay?
very good.
I'll set that up for you tomorrow.
To be able to have a patient ask you for a hug because you were able to keep them out of the hospital, as challenging as this work is, it kind of drives you to get up and do it the next day.
There's nobody better that have been taking care of me.
What we look for is to try and keep patients in their home with their loved ones in the best physical condition that they can be in. And so that's the mission that we're really about, helping seniors make good decisions about their health.
Mrs. Dovin, I'll give you like a video visit hug if I can do that.
Aw.
If you can imagine me giving you a hug. There, we'll do that. And then, but the next time I see you in person, we'll get a real hug.
Okay, good.
Not to make your husband jealous.
Sounds good.
But hopefully we'll see you soon, okay?
Okay, thank you.
So, you know, you can see there you can see the stethoscope, and of course we train those CHAWs. So they're kind of lay people that they're not clinically trained, but we have a nurse educator who just trains them to, you know, here's where you put the stethoscope, here's how you help the provider get the heart and lung sounds that they need to hear. And then that camera, that digital camera is really, really high definition. It gets really great views, better than you could see in person. So, and then, you know, you see it, you know, of course, I just love the you know, she's so cute at the end, you know, you see the patients really love the ability to just stay right in their home and still see their doctor. And so, you know, it's been a very successful program for us. And so, you know, some of the results that we've seen, you see that the health plan was able to save $2 million just in the first year of the program, even with it being, you know, obviously a very resource intensive approach where we're actually literally sending people out into their homes. But the reason we're able to save that money is because, of course, the 34% reduction in hospital visits, 19% reduction in ED visits for that population. And so, you know, it's really kind of a win for everybody. And those patients really benefit from being able to stay in their home and not have to try to get transportation, not miss appointments, not get behind. They've got somebody checking in on their medications. You know, they're staying on their care plan. So, you know, that's, you know, I think a great program. Very proud of it. Now, is that scalable to 2 to 3 million people across central Pennsylvania? You know, and absolutely not. You know, there's no way we're going to be able to send people into everyone's homes. So how do we figure out a way to make this, you know, technology available to everyone, kind of regardless of what infrastructure they have or their technical expertise? So I think we got a few things, resources at our disposal. We've got our regional hospitals. So Geisinger has 10 hospitals throughout kind of central and northeast Pennsylvania. We've got neighborhood clinics scheduled, even more than that, scheduled or scattered throughout the whole catchment area. And is there a way that we can be, you know, so that's hospitals and clinics, and then can we figure out how to support patients in their homes, even if we don't send out a child, you know, person directly into their home? Can we figure out a way to get some additional support to them? And so some of the things that we've been doing just to try to address this. You can see, you know, this really highlights the importance of it. So this is, you know, video visits in the home have become, you know, really ubiquitous. And, you know, certainly not just at Geisinger. I know, you know, really, you can see this all across the country. But I always laugh a little bit at this graph. So I started at Geisinger right at the end of 2018, so about halfway through this graph. And traditionally, we'd done about 100 visits, 150 visits a month prior to my coming. And what you would see if I cut this graph off in January of 2020 is a growth that I was enormously proud of. We got up from 150 visits to about over 800 a month. You know, it's like this really nice growth pattern. And of course, then in March, you know, just completely wiped out. You can't even hardly see that we did anything. But and I think the next month we went up to 50,000, and we've kind of stabilized at about 25,000 a month. But so, and it's, you know, 10 to 12% of our outpatient visits now being conducted via video in the patient's home, which is great, very convenient for the patients. But how do we make sure that everybody has access to this now? Because it is really how we're delivering care going forward. So one of the solutions is, okay, our hospitals. We have hospitals throughout the area. So folks who are, and here, let me orient you to the map here. So for those of you who aren't as familiar with Pennsylvania, what you're looking at here is on this right side is kind of the eastern edge of Pennsylvania. Very far right is New Jersey. Danville is located at right in the middle where it's the GMC, it's Geisinger Medical Center. That's the headquarters of Geisinger. And so what this map is showing is kind of a heat map of how often we do telemedicine consults by hospital. And so you can see it's darkest up here at GWV, that's Geisinger, Wyoming Valley. That's in Wilkes-Barre, Scranton area, which is kind of the closest thing we have to a population center in this general area. And it's, you know, near Scranton and Wilkes-Barre. And so we have a lot of folks, but then also that far left one is GLH, that's Geisinger Lewistown. So that's a town of, I don't know, probably about 10,000 people, far western edge of our catchment area, and, you know, not a lot of population centers anywhere near there. And so someone, if they were going to see one of our subspecialists at Danville, and Geisinger is, you know, blessed to be this kind of pretty large advanced health system. So we have just about any subspecialty you could ask for, but they would previously have had to be transported, you know, about 2 hours to Danville. And then their family members, if they wanted to visit them, would also have to drive very mountainous area through the mountains and try to get to Danville. And so, you know, we've really built this infrastructure out to say, okay, you can be seen by any of our subspecialists, regardless of what hospital you're at. If you're in our system, and actually I don't display it on this map, but we actually work with several outside systems as well that contract with us to provide subspecialty care as well. And so we've been able to get care to folks who otherwise, you know, wouldn't have access to some of these subspecialists. And again, closer to their home. They're able to stay kind of within their regional health center. So that's kind of one step. But then beyond that, that's great for the inpatient setting. But what about kind of clinic visits? Now, in many cases, we're doing these what were formerly clinic visits, we're doing in the home, literally, just through a telemedicine visit. But sometimes we can't do it in the home, either because there's something that has to physically happen, we need a blood draw, something like that, or the patient doesn't have access to broadband, or they don't have a computer, they don't have a webcam. So what do we do? And so I really didn't want the answer to be, well, you know, too bad, sorry, you're going to need to drive to Danville because that's where our provider is. And, you know, like, so you see, like up in Montoursville, you know, very mountainous area, Jersey Shore, very, very mountainous, very remote area. It could take you 2 hours. And if it's snowing, you know, you basically forget about it. And so that's where we really wanted to have the ability for patients to be able to just go to their neighborhood clinic. Most of the people in our catchment area live probably 5-10 minutes. Well, you can see the average distance here on that chart to the right. It's 15, 8, 7 minutes miles. So they're able to go within 10 miles to their local clinic and be seen by whatever provider in our system they need to see. And so and how that works is we'll schedule it, and when we schedule the patient, we'll say, hey, this would be a great visit for telemedicine. Our providers think they can do this one through telemedicine. Do you have broadband in home? And if they say no, then we say, oh, okay, well, I see you are very near this Jersey Shore clinic. Can you get there? Because we've got a telemedicine cart there. And so when you get there, you can just check in. The front desk staff will check in, and they'll just put you in the room with the telemedicine cart. They'll do anything that the provider might need in terms of the stethoscope, things like that. But after that, then it'll just be you and the provider, and you can have your visit right there in your local clinic, even though the subspecialist might be in Danville, might be in Wilkes-Barre. And then increasingly, another big piece of the story is that provider also might be in Florida. And so I bring that up because you'll notice like the darkest color here is Danville, which at first, when I first saw this map, I thought that doesn't make any sense, because that's where most of our providers are. So why isn't the patient just seeing the provider in person if they're going to be in Danville anyway? The reason is because behavioral health. This is almost entirely driven by behavioral health. So we simply cannot recruit nearly enough behavioral health providers to move to our area. Long-standing problem. We've had this long access issue. And so now that we're doing 80% of our behavioral health visits through telemedicine, we've been able to massively improve our access to behavioral health, because we can contract with providers who are in Florida and California. As long as they're licensed in Pennsylvania, then they've been able to see most of our patients through telemedicine. And so again, if one of our patients doesn't have broadband or something like that, we just bring them into the clinic here in Danville, and then the patient is in our main campus, but the provider is in another state. So that's been enormously beneficial, and I think it's been very beneficial also for some of our older patients who maybe just they didn't see the need to get broadband, maybe they can't afford broadband. And then of course in our area, it's not a given that broadband's even available. Like even if you got all the resources in the world, there are some of these areas where you just flat out can't get it. And so this has been kind of another step of making sure that we have availability for telemedicine, regardless of whatever their personal circumstances are. And so I think then the last major topic I'll bring up, where we've been really trying to focus on ensuring that everyone has access to a service, is what's we're calling a virtual urgent care, often called on-demand service. But the basic idea is it's like, and a lot of commercial companies do some version of this. So they may have like a Teledoc or something like that. Increasingly Amazon and just about every retailer seems to be getting into this space. But the basic idea is you got a cold, flu, urinary tract infection, you can dial up a doctor from your home that you initiate as a patient, and then they can write your script or do whatever needs to be done. So that's kind of the big new thing, and so we have a version of that now. I noticed that the uptake for this type of service, because Teledoc's been doing this for well over 10 years now, and the uptake has always been kind of low. It's been like 7 to 10% historically of the people who have access to this type of program actually end up using it. And my hypothesis is that it's a combination of two reasons. One is that it assumes that a patient can triage themselves. So like they'll give a list and say, hey, if you have one of these conditions, you can use this service. Otherwise, you can't. And which is fine. And in many cases, people know if they have a UTI or something like that, but they don't always. And so there's a little bit of, I think, uncertainty of like, am I even a good candidate for this service? How does this work? And then I think the other reason is people, it's easy to forget that it's available. I've for years, like previous employers, I would, HR would give me a flyer and say, hey, we've contracted with this nurse call line. You can call them instead of going to the ED if you get sick at, midnight or something like that. And it's like, oh, that sounds great. I stick it in a file, and 8 months later, when I get sick, I've completely forgotten that I've ever gotten this flyer and have no idea if the service is available. And so to try to kind of combat a couple of these issues, we've designed our service with a kind of an AI assisted chatbot at the beginning. So if you go to the Geisinger website, a little chatbot pops up in the bottom, and then it can direct you however you need to go throughout the website. So it's not just about getting the virtual urgent care. You can also say, hey, I want to pay a bill. I want to get directions to the clinic. Any number of other services. And so the hope is that people get so used to using, this is how I interact with Geisinger, and it kind of points me in the right direction, that it becomes a little more second nature to at least just check in. And even if you're thinking, oh, I'm going to go to the ED, maybe you check in and say like, oh, where's the closest ED? And then the chatbot can kind of direct the patient to the symptom checker, which is then the other piece of that. So if you can't triage yourself and know that, yes, I think I have, a flu, I need to use this virtual urgent care, you can just type in your symptoms in natural language. And then the symptom checker, just using kind of a standard Schmidt-Thompson type guideline, will direct you and say, oh, hey, you need to make an appointment, or you need to go to the ER, or also, hey, you'd be a great candidate for this virtual urgent care. We've got a provider kind of standing by that can see you in 15 minutes. And so now, and this is great, and it's largely, I think, a service that's been targeted to, kind of young professionals and, maybe kind of working moms, things like that. And that's great. And it certainly, we get a lot of benefit from that, but we also want to make sure that it's available for all of our population. Again, we have an older population than most. We don't want to just target, tech savvy 19-year-olds. And so part of how we've designed this is we also have a virtual care assistant, which is a human being. That's just their job title, virtual care assistant. And they're the ones who actually connect the patient with the provider, because at least to pilot it, we actually are just using our existing Geisinger providers. We're actually in the process. We've seen really good results from this, so we're in the process of actually having dedicated staff who will also be Geisinger providers, but they'll be dedicated solely to this service. In the past, we've kind of pulled people from clinics when we needed to. And so this is really kind of what the system looks like. This is the symptom checker that you're seeing on the screen there. And it, just kind of helps them, walk them through very simple language. You don't have to be a medical professional to understand what they're asking you. And then, you see on the right kind of how we might direct them. So it's like, hey, you'd be a great candidate for a telehealth same-day video visit. And so the beauty of that virtual care assistant is they can both schedule the patient, they register them in the EMR, they schedule follow-up visits for them often, but we can also leverage them for the other scheduled in-home visits. So when our virtual care assistant is not doing this work, we send them a list of everybody who's scheduled for, say, an oncology visit that day in their home, and who has not had a video visit previously. And so they have that list every morning, and they call those patients and just ask them if they'd like to go through a quick dry run and see if they have any questions about using the system. And they'll walk them through using it. Now, again, it's super simple, and many times it's not necessary, but I think a lot of times it gives the patient a little bit of extra confidence that, okay, yeah, I know how to do this. This is not a problem. And also helps to ensure that, the providers aren't stuck with, hey, you need to allow access to your camera, allow access to your video, your audio, your mic. That was an issue early on as we were, kind of rolling this out. We don't want our providers to be, tech support. So So that's just another way that we're able to kind of support our patients in the home and kind of leverage these disparate kind of telehealth programs. So, we've seen really nice success with this. We started it off without any advertising, and we found, we got over 100 new to the system patients within the first 6 months. And I wasn't shocked by that, except for the fact that we hadn't really advertised it. So that told me that people were actively searching for this service. That because the only way they would have gotten to it would have been by going to our webpage. And if someone wasn't a Geisinger patient, they wouldn't have really had a reason to go to our webpage. So really the way they must have gotten there was by Google searching, hey, I want like a virtual urgent care, I want care now, something like that. And then getting routed here. And so we found that it's been very useful. And now I will say our largest population has been, I think, women between 20 and 40 years of age. But we have seen a very substantial number of Medicare and over 65 patients use this service. So again, it's important not to just make assumptions about who's going to find what type of service valuable. So just to kind of conclude, definitely can't say it enough, like the survey data really does show, do not make assumptions about demographically about your patients and who's a good telemedicine visit or good patient for telemedicine, who's not. There really isn't a lot of demographic disparity about who appreciates telemedicine. And then particularly if you can keep your workflows simple, which I would argue you should regardless. And invariably when I talk to folks who say, oh man, wait, we don't get, very many people other than, the younger folks using our telemedicine. And I ask, well, what's your workflow? And I'm like, well, that's why. I'm sure. It's like, if you design a system that requires somebody to be an electrical engineer to get a telemedicine visit, that's on you. That's really not your patients. And so I think if you really design it thoughtfully, you can serve a wide swath of your population, which I think is going to be increasingly important. And I think, again, it's important to be very transparent to your patients. I think that's kind of the one caveat we've seen from the patients is that, yeah, it's great, it's convenient, it's easy, I like it, but how do I know that I'm really getting a full visit, that I'm getting everything you need to give me good medical advice? I think as we gather more and more data from this, it's great. We need to publish it. We need to do all those things. We need to make sure the policymakers are aware. We also need to share that with our patients. I think it's important for everyone to be on the same page about when it's advisable, and also be equally transparent about when it's not. If we find that, technically we can do this telemedicine visit, but most of the time we find that we have to bring you back anyway because there's a follow-up, then just don't do it. There's no need to do it for its own sake. And I think it's important to kind of build that trust with the patients that we're only offering the telemedicine when it's medically advisable, and we're collecting data to find out when exactly that is. And then, lastly, I think, the big point I always make is that I think telemedicine has long been, the promise of telemedicine has long been, this is great. It's going to increase access to care. It's going to increase access to subspecialties that, remote areas have never had before, or rural areas. And because of that, it's going to decrease disparities in healthcare. And I think it absolutely has the potential to do that. But it's going to be dependent on us in the industry being thoughtful about how we design the programs and how we roll them out. Because I worry it's also got the potential to increase health disparities if we're not careful. Because I could easily see in the future, we already actually at Geisinger, we ask when we are scheduling a telemedicine visit, one of the first questions we ask is, do you have broadband? Do you have a smartphone? Do you have a computer? And if the answer is no, right now we've built up this other process. So, okay, well, can you get to your nearby clinic? But, I think a lot of folks aren't necessarily going to bother. And even that, it's not the ideal scenario. You know, I think obviously ideally would be, yeah, we've got great broadband access to everybody in everybody's home. And then I could see it as time goes on. I think there's going to be more and more tools that'll probably start to be marketed to individual people, you know, stethoscopes, digital stethoscopes. Eventually, are we all going to have that in our medicine cabinet? And if so, that's great, because it'll greatly expand the pie of visits that we can conduct via telemedicine into the home, which I think is great. It's more convenient, it's lower cost. But if those things aren't free, and so if we start to add to our list of things that, okay, if you're going to have a telemedicine visit, you have to have the following things, I think we run the risk of it becoming kind of this niche convenience service for people of means who are like, well, I work from home all day. Sure, I've got a stethoscope, an otoscope, and you know, I just, you know, and then everybody else is like, well, sorry, you're just gonna have to drive to the clinic. And I think that's where I think we've got to be real wary and be thoughtful about how we build our programs, and really always try to keep in mind, okay, this is great. This is kind of the basic service. What additional things can we build around this to ensure that everybody gets access to these specialists that we can provide through telemedicine, whether they don't have economic means, if they are older, if they don't know technology very well, if their reading level is low, we don't just immediately throw them out and be like, well, sorry, we can't accommodate those. Like, be really thoughtful about trying to, you know, design your program so that you can accommodate those. Can we get those virtual care assistants to kind of help out and facilitate that meeting? And so, you know, that's what we're working with. And, you know, we're definitely at the early stages, and I definitely would love to hear if anybody else has kind of thought other things on this and other tools that they're using to help make sure that everybody gets access to the service. And you know, I think we're still at the early stage of this, so we can set the ground rules now that will really help ensure that we do decrease disparities in care. So thank you very much, everybody, for attending, and I'm very happy to answer any questions.
Thanks, David, so much. That I love, especially that health equity piece. I feel like that's instrumental in kind of keeping the right focus on telehealth. So it's really good to hear, especially, you know, like the future goals. It's awesome. I want to take a quick second. I think, Caleb, we were working on making sure that the polling questions would work. Oh, and there it is. So if you could complete the post-polling question for us, that would be wonderful. We had a small tech hiccup for the first question, but it looks like it's working now. And I think at this point, we can go ahead and move in now that your polling is working through. If anyone has a question, you would like to either put it in the chat box, or if you wanted to unmute, you can as well. Any questions for David?
I'm in Greene County Hospital in Utah, Alabama. I've got a few questions. First of all, are you doing this under a home health CON, or how are you doing this?
So the Geisinger at Home program was just purely sponsored by the health plan. So essentially they paid for the cost of it, and they just found that they didn't limit it actually to only health plan members. They targeted those, but we did have some other payers, members of other payers that would be in the program. And essentially the health plan was happy to eat that cost just because they were able to save so much on their members, you know, on those the ED utilization and the readmissions.
Yeah, that was one of the questions, was how is it being billed? Another question is, how do you determine when to send a child and when to send a nurse?
Mm-hmm. Yeah, so I think it's they go, I think, on I can't remember what the cadence is, maybe every 2 weeks or something. And so if the CHA sees something that's a little bit more medically concerning, they would probably send the nurse the next time. And then somewhat just availability, I think, too. But yeah, they kind of work it out through just visit to visit, and obviously with the doctor's advice as well.
Yeah, I was wondering if they were just kind of following home health requirements, maybe once every 2 weeks a nurse has to go, or once every month a nurse has to go. Or, like you said, if there's something that's unusual, then the nurse makes a visit, maybe the next day or whatever. I was just curious as to how that was being done.
Did anyone else want to chime in from, I didn't get anything in the chat yet, but if anyone wanted to unmute themselves, you could definitely chime in and ask a question of David if you'd like. David, I'd like to ask one quick question before we hop off the line. It's just in reference to the patient engagement surveys. So I saw that you said in the talk that you guys were doing them pre-COVID, post-COVID. With the survey, is it actually integrated into your telehealth visit? Is it being sent to the patient like after the visit is completed, or was it independent of the visit?
Yeah, so it's sent after the visit. It's actually just part of our Press Ganey regular surveys that we do for like clinic visits and hospital visits, and we also then have a telemedicine specific question that goes as well. So but it's not baked into the platform itself.
It's not baked into the platform. Okay. I wondered that just that data is really empowering and kind of where you take your program, I'm sure. Have you guys leveraged that data to kind of see where there are potential areas you could move the needle on as far as the program, or has it more just been about just patient experience overall?
Yeah. So it's been a big piece of honestly for our leadership. So our CEO kind of sat down and said, okay, what all are we doing now? I know we exploded telemedicine during COVID, like where are we at? So I listed all the things we were doing, and I was very proud of it. And he's like, okay, that's great. Now, how do we know which things that we should be doing? I understand we did it because we had to, but what do we double down on? Is there stuff that we trim back? And of course, my honest answer at the time was, I'm not sure. Like we did it because we had to. I think it's a good idea. And so this was part of that. I think we were able to see that, okay, look, our patients want this, and so, I mean, obviously, we did a lot of the work too on the medical appropriateness of it. That's key. But after that, then it's like, okay, yeah, but why not just have them come into the clinic? And I think, that's where we additional survey data that I didn't display about, some of the barriers of coming in. And so I think that's been very helpful there. And then, yeah, certainly, as if they've said things about, sometimes we'll see something about, well, I didn't know my provider was running late, which of course they always are. And so I didn't know, like, was I in the right place? And so, I just hung up because I wasn't sure, and so we learned, like, oh, we need to have built into the platform a thing that says, yes, you're in the right place. Please hold on. Your provider will be here shortly. Things like that. Again, I should have thought of it ahead of time, but those surveys, you kind of help you, like, oh, of course, right. Yeah, I can see why a patient would have, so yeah, it absolutely has driven a lot of our operational kind of improvements.
That's great. I think that's a nice thing that our sites, it's kind of like a starting point, knowing where you're going to take a project and how you're going to leverage it. So we appreciate it, because that's going to be an important piece for anyone that's opening a new service line or potentially expanding their own, the service line that they have. I don't have any more questions at this time. I want to again thank David so much for this wonderful talk. And Caleb, if you want to pull up our contact information slide, I don't know if we can right now. Either way, we oh, it looks like you switching over just in case. But we are very excited to have you guys on the line today, and please feel free to reach out to any of us at the center. We will be in contact, and we also have those additional 3 talks that are coming up in the future. So we will very much look forward to see you next week. Thanks so much, everyone, and have a great day.